好，各位同事，歡迎大家嚟到我哋 Child Sim Talk。今日呢就係正月12，咁呢都要同各位拜年，希望大家身體健康、龍馬精神，心想事成嚇。我哋早啲過翻啲正常生活。咁啊，今日開始有人可以打針咯嚇。咁啊，講起打針就係藥啦嚇。咁啊，所以今日呢就同藥都有關係嘅。咁原來我哋今日呢，我哋都差唔多用年幾兩年啦，我哋第一次請我哋香港嘅藥劑師上嚟 Child Sim Talk， 咁所以第一個上嚟梗係好有份量啦，呢個speaker。咁我留翻阿 Freddie 一陣間先介紹。咁藥呢就我覺得好重要嘅，作為醫生呢，就即係除咗 make diagnosis 啊 investigation， 最終就要俾藥啦。咁俾藥呢，就其實我哋不嬲嘅重點呢，就點樣開一隻啱嘅藥啦，所以有咩 MOE 啊、PMOE 啊，又驚錯啦，有啲 risk management 啦，又講啲 pharmacokinetic 啦。但係咧，我哋又好少諗咧啲藥咧，啲細路仔食唔食嘅喎？咁啊，早幾日先有個媽咪個小朋友出院咧，佢又問我哋啦，問我隔離啊 Alice， 佢話：喂，我 BB 點樣食藥？我唔知點餵藥俾佢食喎咁樣。咁原來即係食藥，即係對一個小朋友都係好困難嘅。但係食藥呢，又引起好多呢啲童年陰影喎。我隔離呢個咧阿 Mandy， 我哋今日導演呢，佢頭先講食藥呢，佢話你唔好再俾嗰啲白色嗰啲藥同橙色嗰啲藥。我話到而家呢，咁多年之後，我都好驚嗰啲藥嘅。佢啲白色嗰啲有曱甴味嘅，諗起都驚啊咁樣。咁所以原來食藥呢，非常之重要。咁今日嘅題目咧就好貼題㗎啦，就希望Celeste 講完之後咧，睇下 Mandy 仲有冇咁驚呢個食藥啦。其實 Alice 都係話嘅，佢個小朋友即係細個嗰陣時咧，死都唔肯食藥水嘅。你俾粒藥丸好地地，藥水佢唔食嘅。咁你睇下今日Celeste 講完之後咧，會唔會對呢啲問題都有幫助？好，咁我將個時間咧交俾阿 Freddie。Freddie 我好朋友啦，即係認識咗好耐，
唔該晒，
一齊 commission 呢個兒童醫院。我亦都去過佢藥房參觀，真係其實佢擺咗好多心機落去。咁咧就今日好多謝佢咧上嚟做我哋個 host 同埋做呢個 moderator。咁將個時間交俾阿 Freddie。
好啊，唔該晒多謝，係啦。咁即係我由而家開始轉一轉翻做英文個 channel 啦，係啦。就welcome to the Sim Talk。We all know that medication only works if they are actually taken and in a proper way. That's why as a pharmacist, one of our focus areas is on the medication adherence. And for at Hong Kong CH, we always work with the child and his or her carer to streamline the whole the drug taking process. And today we are honored to have an expert to share her in-depth view in this aspect. Let me introduce Dr. Celeste Ewig. Dr. Celeste Ewig is actually the board-certified pediatric pharmacy specialist. She is currently the senior lecturer at the School of Pharmacy, CUHK, and also the honorary senior pharmacist at Hong Kong Children's Hospital. Her topic today will be on medication adherence in children. Let me pass the time to Dr. Celeste Ewig.
Okay, so thank you, Freddie. Well, welcome, everyone. Thank you all for joining this afternoon. So I think all of us have at one point or another taken medications, either from a young age or maybe a lot older. But the title of this talk, as Freddie has introduced, is medication adherence, specifically in children. And so why children? Children actually has a lot of unique things when it comes to medication adherence. And for anyone who has tried to give medications to children, we know that it can be quite challenging. So for today, I will introduce to you the topic about medication adherence and also share with you some local perspective. What are Hong Kong children taking? And what can we do to actually improve the process? A short disclaimer, when I decided to talk about this topic, I didn't realize it was a very big and complex topic. So for today, because we only have an hour or so, I will just touch upon some of the points that I think as pharmacists we see more directly with, and also hopefully some of the things that you can implement into your future practice. So at any point, I do welcome questions. So, and also I welcome further discussions and conversations. So even after the talk today, if you choose to contact me, I welcome, discussing the topic further, because really it's a big topic to cover. Okay? All right, so let's go and get started. So the outline for today will be quite simple. I will first introduce the problem, and again, just introduction, not thorough discussion. Then I will talk about some of the factors that affect adherence and how do they actually differ from adults or even older patients. I'll talk about how these factors relate to the medications children take, especially in Hong Kong, because the audience is primarily Hong Kong. But you will see that a lot of the factors that affect adherence are not specific to Hong Kong, but are actually quite universal. The next thing I'll also share with you is what can we do about them. So I think introducing the problem is one thing, but what can we actually do to resolve some of these issues? And lastly, I'll touch a little bit about how to measure adherence. And again, hopefully throughout this talk, you will appreciate not just the scope of the problem, but realize that there's a lot of things that we can do. Okay, first, very standard definition of terms. I'd like to start with just a simple difference between compliance and adherence. And I think medication compliance is a rather traditional term that we've used in the past. And I think for all of us, we've encountered this term in school. But really what we're moving towards is medication adherence. And the difference between them is that adherence denotes a communication and conversation between both the parent and the prescriber. So hopefully it's an agreed upon recommendation rather than the traditional compliance, which is often unidirectional. So for the purpose of today and also for future discussions, what we're trying to emphasize is really to encourage adherence, where both parties, both prescriber, parents, and the patient, be it the child who's a young child or adolescent, will really feel comfortable with the recommendations that's being given to them in terms of their treatment. Okay. So while medication adherence is the goal, oftentimes what we will see is non-adherence, and it's actually non-adherence that tends to be a bigger problem. Okay, so just again some short reminder. So some quick reminders. We all know that drugs don't work in patients that don't take them. So it doesn't matter if you have the most effective blockbuster newest medication. If the patient doesn't take the drug, it won't work. And so really what we hope to do is find ways to encourage the drug taking process. While non-adherence may not be a problem in some cases, there are cases where it is a major issue. And so these would be for children with chronic conditions. And for these subgroup of the pediatric population, non-adherence is actually a major cause of treatment failure. And treatment failure means not just the child is suffering, but sometimes it can mean hospital admissions, it can mean unintentional visits to the clinic, it can mean more medications. And so really the root cause of it is the non-adherence problem. And so this, again, I cannot emphasize how important it is for the child to take the drug. Additionally, non-adherence is also associated with slower recovery time, so longer time for the child to feel better, to get better. It's also associated with increased healthcare costs. So similar to what I've mentioned, requiring hospital admissions, more drugs needed, additional medical visits, and similarly can also lead to unnecessary medication use, toxicity, poor mobility, and poor quality of life. And so I think we can all agree, even though I've presented a very few factor or associations with non-adherence, that non-adherence is a problem, and it's a problem with no upside, and also it's something that hopefully we can address. So this is really what I hope to further discuss in the next few minutes. So now that we've talked about medication adherence, how is it different in children? Well, in children, it is actually a multifaceted problem, and it's complicated by what we call a triangle of care. So the triangle of care refers to you have the prescriber who is prescribing the drug, then you have the parent who is giving the drug, and then you have the child that's taking the drug. So oftentimes, this triangle of care is associated with many factors individually. So together, it just makes the process a little bit more complicated. So in children, again, the adherence rate does vary quite a bit. So there are reports that say it ranges from 11 to up to 93%. And I'm actually curious to know who these 93% are, so we can interview them. But the median hovers around 58%. And for children with complex chronic diseases, which is really a subgroup of populations that we worry a lot about hospital readmission, the adherence rates are anywhere below from 50% to below 50%. So you can see adherence rate is only between 50 to 60, which is actually not a lot. There are many reasons for this, and I've listed a few here. Some say that they are tired of taking the drug because they have to take a drug for an extended period of time. They're also concerned about the multiple medications. So I've had patients who tell me they feel like they're just taking like a handful of M&Ms, and they wish that it was a handful of M&Ms, and I think we can all agree with that. And also they've suggested that periods of symptom remission, which to them is synonymous to cure, and so because they're not having symptoms, they think they don't need to take the drug. Now the next group of pediatric patients that are notorious for non-adherence are actually the adolescents. And in this group of patients, the adherence is actually a lot worse. So again, the data is showing between 5 to 15%. Now, there are many reasons for, again, why adolescents are particularly difficult. Teenage years, the rebellion behavior that we see in these groups is also another challenge. And so I guess, what I'm trying to share with you is that within the pediatric population, we see a wide range of diverse adherence rate. But within the population, each subset of the population also has unique challenges. Okay, so when I went through the literature and I looked at what are the reasons that are reported for non-adherence, I found that there was actually quite a few. So I've listed here 20, but there's actually a lot more. But these 20 were the ones that I noticed came up repeatedly again and again. So I'm sure some of you have encountered this in your patient. You can see that it ranges anything from simply forgetting the drug. Okay, right here. Multiple drugs is another one. You'll also see that parental factors, like the parent being too busy, is one reason that they were non-adherent. Some of them actually say that the quantity of the dose, so how much medication they have to take, is a reason to deter adherence. And then, of course, for the adolescents, older patients, and actually sometimes younger patients, so you have resistance from the child. And this, I know a lot of parents will be nodding their heads saying, yes, I know, because fighting the child to take medication is a source of stress, I think, that is undocumented for parents. Then there's other things like timing with the food, fear of adverse effects, insufficient quantity. They don't understand the medication, known adverse effects, and so on. So while I've listed 20 here, I'm sure there are a lot more, but I think we can appreciate just the scope and complexity of non-adherence in children. And these are only the ones that have been reported. There are many others that are intrinsic that have not been reported by the patients. So if we look at the factors, you can actually kind of divide or categorize them into areas that affect medication adherence and layers of what affects a child taking a medication. There are factors that influence that are specific to the child themselves, so one of them being age. And so younger patients may rely on their parents or caregivers to take the medication, and so things like busy parents or having to go to school or scheduling conflicts could be a factor. Comorbidities is also another factor. So children having multiple conditions. Social stigma is actually a big factor, and some children do feel that by taking medication, they feel that they are not similar to their peers, and so they often feel like they are outsiders, and that does contribute. In terms of parents, things like family environment, health and medication literacy are also important. But what I will focus on mainly today is going to be the prescribed medication, because as pharmacists, this is what we see. Thousands of drugs every day, and also of all different colors and formulations. So this is what I will be focusing on. But towards the end, I will also touch upon what we as healthcare professionals can do. it's a multifaceted problem that requires multidisciplinary approach. So there is just not one solution to it all. So, in addition to the factors that I've listed, I also looked at, okay, what were the most common reported reason? And unsurprisingly, taste was actually the number one reason for non-adherence in community-dwelling pediatric patients. The second being school, third being apparent recovery. Now, this is just from one study. However, I think a lot of us will agree that taste is a major issue. Other things like multiple drugs, sleeping, the quantity of the dose, etc., are also reported reasons. Next, if we look at themes from the caregiver, so the column on the left looks at reasons from the pediatric patients themselves, but the column on the right is more from the point of view of a caregiver. What do they think? And so here we find that there's actually several themes, 5 here that I can present to you. The first is actually competing beliefs. So there seems to be disagreement or discordance between what the caregivers believe and what the physicians are prescribing. So that disconnect is one source of potential non-adherence. The second thing is refers to the difficulty and unpalatability of the treatment. So this is very similar to the taste that we see, and also multiple drugs. Child resistance, as I mentioned earlier, struggling to get the child to take the medication. With younger children, you can definitely use some sort of minor force, if I can say that, or pressure. But for older children, this is not the case. So it's another reported major factor for caregivers. And then the last two were kind of things that are intrinsic for the patient. So these are preserving family relationships, because caring for a sick child can cause stress to the family, and reminding having the parents reminded to take to give the medication, scheduling it around their meals, scheduling it at a proper time. All of these can actually cause some stress to the family relationships, and also have this perception that the child is not normal. And so a combination of all of these can lead to the complexity of the problem. Now, again, because I am a pharmacist, I will focus mainly on the factors that relate to medications. So I've decided to pick 3 that I will just share with you a little bit more for today, and these are pill or medication burden. I'll touch upon a little bit about drug formulation, and then lastly, palatability. So I hope I don't burst your bubbles by only talking about these 3, but I think these 3 are definitely something that all of us have encountered before, and hopefully the solutions I provide can help you in your future practice. So the first one is pill burden, and pill burden refers to the number of pills that a patient takes concurrently at a regular basis. This is where it refers to the quantity, and usually this refers to concurrent, meaning that how many medications, pills that the patient takes at the same time. This factor has been associated or has been determined to be a significant factor for medication adherence. And so I've put just some statistics here, so some information here. So for children who took less than 2 different medications, 82% of them were adherent. But when the child starts to take more medications, the adherence drops to 73%. Polypharmacy is a term that we usually think about in geriatrics, and it's a fairly it is used in pediatrics. However, the challenge with polypharmacy in pediatrics is that there is no standard definition. Polypharmacy is a defined risk for non-adherence. However, because again in children, there's a lot of variations in terms of the definition and also what constitutes as polypharmacy. The relationship is still not that definitive. However, we can all acknowledge that increased medication quantity, or increasing the quantity of the medication and pill burden, will lead to an increased risk for non-adherence. So a few a few years back, we did a study actually to look at chronic medication use in Hong Kong. And this is stems from my curiosity trying to understand the local population better. So I wanted to know, what are Hong Kong children taking? Okay, we did a study at the Prince of Wales Hospital where the objective of the study was to determine the prevalence of chronic polypharmacy, because I think this group of patients will be more at risk for the non-adherence I mentioned earlier. Also, I wanted to see what factors were associated with polypharmacy. And I wanted to look at patients in the outpatient setting because these are the chronic medication users. And so polypharmacy in this group would be chronic polypharmacy rather than the short term that we see when they're admitted to the hospital. So if there were any problems that may arise, it would be more detrimental and perhaps more frequent in this population. So we did a 12-month retrospective study where we looked at the prescribing records from all of our wonderful doctors from the Prince of Wales Hospital. And we looked to see what were they actually prescribing. And unsurprising, they were prescribing a lot, mainly because it's a large tertiary medical institution, so it's unsurprising. So we looked at the prescribing records. We looked at specifically medications where the intended duration was more than 30 days, so again, chronic use. And we adopted the traditional definition of polypharmacy being more than 5 medications. We excluded some medications, so topical products with no active ingredients. We also excluded repeat or refill prescriptions and those that were kept on record. So during the 12-month period, we actually identified close to 4,000 patients with more than 1 chronic medications. These 3,920 patients were prescribed over 16,000 medications. So we decided to review all of these prescribing records. These data are unpublished. However, the manuscript is currently under review, so we are excited to be able to share Hong Kong data once this gets out. So what did we find? We first broke down to the medication taking pattern according to age group. So you can see that I've divided it across the different age groups. So 0 to 2 years old, 2 to 6, 6 to 12, and then our adolescents group. You can appreciate that while most of the patients are taking between 1 to 4, and I think majority of them would be taking 1 to 4, the average being 2.4 medications for each child, there was actually a minority of patients that were taking more than 5. Okay, so for these few patients, over 300 patients in our population were taking 5 or more, and some of them were actually taking 10 or more. So while this might sound like a small number, 300 per year or more than 300 per year is actually not a small number. And so in this group of patients is what we hope to perhaps enhance our approaches when we tackle non-adherence. So the next thing we looked at is the factors. So what kind of factors would influence the increased use of medication in our population? And we defined several factors a priori. We looked at age, gender, and what class of medications. We used logistic regression to determine the association relationship. Now, the results were actually both surprising and unsurprising. First, when we look at the age, we thought, does age actually influence the number of medications that patients use? We did see a significant correlation between adolescents versus the younger. So when you compare children between 12 to 18 years of age versus those that were younger, we did see that the risk of having multiple medications, specifically more than 5, was a lot higher than our reference group. And the trend does seem to increase with age. So for those 2 to 6, 6 to 12, 3.5, 5.6 respectively, and then those older were close to 7. We did not find any association with gender, and this is actually something that was different from overseas studies. There were some studies that suggested that male children were more likely to have a higher medication load. However, in our population, that was not the case. So the first factor that we saw a positive association with was age. Now, the next thing was we looked at the therapeutic class. Now, we were unable to use the ICD-9 codes to check for the association because we did find that there were some missing information with the ICD, and so we decided to go with what we have, which is the medication class themselves. You can appreciate again that antihistamines are the most frequently prescribed medications in children, followed by topical corticosteroids, inhaled selective agonists. These are your salbutamol inhalers. Then you have drugs used in allergy, nasal allergy. These are your intranasal corticosteroids. All of these drug class, which are often prescribed in clusters, are actually associated with polypharmacy. So while we do not have the actual diagnosis of the patient, we can see that based on the drugs that they were prescribed, what kind of conditions that is associated with them. Other factors that were, or other classes of medications that I was associating or I was expecting to have a positive factor where in our study we did not, was actually the control of epilepsy. And so for this group of patients, I guess one possible reason is that they tend to have, first the age group is definitely a factor, but most of the times you can control them with a fewer number of drugs, so no need to go to 5 or more. The other thing that was also quite surprising was the use of, sorry, my vision is really bad, but drug use in megaloblastic anemia. So these are your folic acid supplements. The next slide also shows, continuing on the review of the class of medications and whether they're associated with polypharmacy. Insulin is actually one thing that I think for adults we would expect this to be a positive correlation, but for children we were actually seeing it wasn't significant. Now, the largest significance was actually found in children who were taking glucocorticoid therapy. So these are patients who are on systemic steroids, and also patients who are taking vitamin D supplements and calcium supplements, most likely because of long-term steroid use, and other skin conditions such as emollients, drugs that are used for psoriasis, and so on. So while the results are quite varied. We have a wide range in terms of our risk. We did see that based on these factors, we can appreciate some of the things that we can observe in our own pediatric population. The first one is that polypharmacy actually hovers close to 8% in an outpatient setting. So these are chronic polypharmacy. In adolescents, the risk is much higher, and with certain medications, certain patients who are taking a class of medications, their risk is also higher. So how does this relate back to our topic about medication adherence? Well, we do know that these factors increase the use of the pill burden, so medication burden, and most likely these factors are also placing the patient at higher risk for non-adherence. So while we cannot change the age, the children will grow up. We cannot change some of the medications that they require. So if they require systemic glucocorticoids, we definitely will give them this. However, we may want to review the list of medications that some of these higher risk patients are taking to see if we can streamline them and decrease at least the pill count. Okay, so that is just a quick snapshot of pill medication burden. Then I'll talk about drug formulation. Drug formulation in children is another big topic. It can be a topic in its own, but again, for the purpose of today, I will focus how it relates to adherence. So we all know that the lack of age-appropriate formulations is a constant challenge. And I think this is an understatement. It is a constant challenge for many, many, many years, and probably will continue to do so for many more years until we're all retired. So this is a challenge that we constantly see in the pediatric population. Now, when we did the review of the more than close to 4,000 children in Hong Kong, we found that about 16% of children 0 to 2 years old were taking tablets or capsules. Then for children 2 to less than 6 years old, close to 18% of them were also taking tablets or capsules. And so for anyone who's ever given a tablet or capsule to children this young, we know that this is nearly impossible. So we have to do something about them. There are several options that we've been having to tackle the issue. The first is the conventional method where we do dose manipulation with dispersion. And this is where we can use a mortar and pestle to powderize a tablet, dissolve it in some water, extract a small amount, and deliver that amount to the child. This is the conventional. I'm sure we have all done this in the nursing wards, and this is also the approach that oftentimes we educate the parents to do. Then I'll talk about extemporaneous compounding because, again, I am a pharmacist, and this is something that is a bread and butter and a very traditional thing that we have done in our profession. And then the last one I'll talk about or introduce some new devices that are helping to tackle this drug formulation problem. So to kind of illustrate the challenges with dose manipulation and dispersion, I will share with you one study that I thought was actually quite interesting. Now, before I go to the study, let me just introduce what does dose manipulation mean, because I think oftentimes we may not be familiar with what this means and what it encompasses. So dose manipulation refers to the crushing, the dispersing of the tablets, then withdrawing a small fraction. It's a very fancy term to say what we already have always been doing. But broadly, the term also refers to opening the capsules, mixing the capsules or the tablets with food or other substances, juice, milk, prior to administration. It can also refer to cutting or any kind of manipulation of the formulation. So anytime you change the formulation from its original form is dose manipulation. And I think we are all guilty of this, me included. Okay, so what are some problems that we see, that we may not know about this approach? So I pulled a study where the investigators looked at different aspirin tablets and what happens to these different tablets while we're adopting this dose manipulation and dispersion. So this was actually an interesting study because they used aspirin, and this was actually conducted in a children's hospital because, as we know, aspirin is an antiplatelet that's used for many conditions, Kawasaki, for patients with cardiac issues. We revert to aspirin. Aspirin also has different formulations. So some of you may be familiar that it's available in chewable, it's also dispersible, and there's also different strengths. So what the investigators did was they took one tablet of each of these different formulations, and they placed the tablet in, they pulverized the tablet, grinded it up, and then they put it in 10 ml of water for about 3 minutes, and then they watched to see what happens. The picture here, which is from the article, shows you what the different formulations will look like after 3 minutes. And I think just visually you can appreciate that there is a difference between the dispersion of the various formulations and also with the strength. There are several zones here, zone 5, zone 2, and zone 1, and I'll come back to that because this is basically the different sections where they will do the withdrawal of the solution that they use to check. So what did they find? First, they wanted to see of the 4 different formulations, all suspended and all treated the same way or all manipulated the same way. Was there actually any difference in the intended dose? Okay, so they extracted a portion of the drug from the top, which is the zone 5, and then they extracted a portion of the drug from the bottom, which is zone 1. Okay. Now, all of the medications before they actually extracted it has been resuspended. Okay, so there was no supernatant, or there shouldn't be any supernatant portion of the solution. And then they checked using HPLC to see what the intended dose was. I think you can also appreciate that even with a very similar strength between 75 and 81 milligrams, there was actually a difference in the intended dose from a dispersible formulation versus a chewable. And I think when reading this article, it reminded me that oftentimes we choose a chewable because we think it's the easiest to dissolve, but actually a better formulation would have been like an actual dispersible tablet. So the numbers are the data that the results of their study are shown here just for you to appreciate the difference in intended dose between the 2 formulations. Next, they wanted to check for dose accuracy and precision. And so they looked at, they used several methods to check for this. They used passive dispersion. Then they also did a mixing with a syringe, and then they did stirring with pumping. And pumping meaning that once they withdrew the solution into the syringe, they actually pumped a few times to ensure more uniform distribution. So across the four methods of mixing the dispersed tablet, again, you can see that there are some variations between the method of extraction and also the volume that they used across the four formulations. So method 1 is where they just stirred the solution and extracted 1 ml. Versions 2 and 3 is where they stirred and pumped and extracted either 1 or 2 ml. And again, if you can look at the different formulations here, you can see that dispersible formulations versus the chewable formulations and so on, the accuracy of the dose does vary depending on the methods that they used. So for the chewable formulations, the accuracy and precision of the dose hovers around 36% versus the dispersible one hovers at 80% or more. When you have the pumping, it does show a little bit more consistent results across. So even though you are stirring and pumping, it does suggest that it has a little bit more uniform consistency. Okay, so that's with the traditional method of dose dispersion and also extraction. I'll talk next about another method that we can use to address the formulation, and this is extemporaneous compounding. So for the pharmacist audience out there, you are very familiar with this, but for our non-pharmacist colleagues, extemporaneous compounding is a way of preparing a medication in terms of a unit of issue. And typically we do this for relatively immediate use, although the solution is stable for up to 30 days, if not more. It is performed in many hospitals that serve pediatric patients, so Hong Kong Children's Hospital is going to be the main hub for the extemporaneous compounding in the future. And again, we do this because of the lack of commercially available formulations. Before we do this, we do have several procedures. So first, all preparations and all formulas must have a validated procedure, and we do have very specific storage and stability information. The formulas are checked in analytical labs to verify stability and information. So the extemporaneous compounding that we do, where we dose manipulate a tablet into a solution form, is not as simple as it looks. There's actually a lot of steps and checks before we dispense that product to the patient. So what does it look like? Here's an example of what a formula would look like, an extemporaneous compounding formula. This one is from the Prince of Wales Hospital. It's a few years dated. However, if they have updated it, I'm sure it will. The formula will be consistent. What you can see is that you have designated shelf life, and this shelf life of 60 days has been tested. We also have very specific containers of how the solution should be stored, and also the temperature. And all of these information have been verified. We then will have the formula of what ingredients we would need to make these solutions, and then finally a very specific procedure of how to actually carry out this compounding. Now, I mentioned that this formula and the preparation that are produced from this formula are checked for analytical labs. And here I will just share with you just one of the analytical labs that are able to do this. So the CUHK School of Pharmacy, we do have a quality assurance unit that has where the service is actually accredited by HOCLAS, which is the Hong Kong Laboratory Accreditation Scheme. The unit is accredited to analyze all pharmaceutical products and beyond. So even biologic samples are able to be checked and tested for analytical validity. And our quality assurance unit or lab within the School of Pharmacy is also recognized by the China FDA for bioequivalent studies. So I share this with you just in case you're curious about the extemporaneous compounding. And if you, again, want more information, I'm happy to share that at a later time. Okay, so how does this relate to our topic of medication adherence? So this is, again, just to share with you that this is an option for patients to avoid a dispersion method. So if it does take some diligence to prepare a good dose dispersion method. And for busy parents where they may not have the time to actually grind it well, suspend it well, do all of the things that are necessary to ensure a uniform dose or a precise dose, then this might be one option. Okay, and the last one is just to introduce to you guys some devices that are coming onto the market. This product is from, I believe it was from Canada. However, there are other similar products that are available in Hong Kong. And prior to the talk today, I was just talking with Freddie about the devices that are used in Hong Kong Children's Hospital. So there are many products available. However, the concept is quite similar. These devices came in the market primarily to facilitate to move away from the dose and dissolve approach. So here, the parent will just place a number of tablets into the container, add until the marked line, shake well for 5 minutes, ensure that the tablet is dissolved, and then use this syringe to withdraw the amount needed. So it sounds simple enough. Hopefully it is. But just as a reminder, there are some challenges as well. So what does the situation look like in Hong Kong? I asked Freddie for data from the Hong Kong Children's Hospital. How often are we actually using this approach? And it is quite favorable. So in the 6-month period, there were about 241 medications that were dispensed using this approach. So it's a nice alternative to the traditional method where the parents have to crush the tablets, mix it in water, and then extract it themselves. With this approach, the device is calibrated, it is measured, there are units available so they can withdraw exactly 2 ml, 2.5, 2.75 if you want. Actually, I'm not sure if it goes to 2.75, but at least it's a lot more accurate than a typical, our conventional way of doing this. And then just as a reminder, because we are using water to dissolve the products, this approach is only applicable to tablet formulations where the medications are highly water soluble. Okay, so how does this relate to our topic about adherence? Well, while I may not know whether these suggestions will improve adherence, I do know that will at least remove the barriers. And so one thing that we can think about is that dose manipulation, as I've mentioned earlier, is an integral part of the medication administration process, and for a long time. And until we find ways to increase the access to child-friendly, commercially available products, this will always be an integral part of our care. Formulation of tablets intended for dose manipulation do affect the extent of the dissolution as well as the dose accuracy and precision. So when you're selecting your tablets, when you're going to IPMOE and selecting your medication that you want to dispense, you may want to consider this as a factor. Manipulation methods, while tricky, there are ways to improve it. So again, we can ensure that sufficient counseling has been given to the caregiver and also the parent. And hopefully by removing all of these barriers, we can improve medication adherence by improving by decreasing the challenges that are related to the formulation of the medication. Okay, now the last factor I will talk about is palatability. And palatability is one of those things I think we can all agree with. If it tastes bad, nobody will want to take it. So again, just a quick simple definition of terms. When we say taste, when we ask a child about taste, we're actually asking them also about palatability. And palatability refers to not just the taste, but also the smell, the aftertaste, and the texture of the oral medications. So things like suspensions, which tend to be very gritty, can also affect the palatability, but children will often report them as taste. So when we're thinking about palatability or taste, let's think about this in a more broad manner. There's a lot of research on taste and taste buds, and we do know now that it is affected by age, and children are actually a lot more sensitive to taste than adults. With the advent of precision medicine and genomic medicine, now we know that there are specific genetic variants that make children more sensitive to bitter taste. And this particular gene, if you guys are, anyone out there is interested in changing the taste sensation of children, this is known as a bitter gene. And it has been associated the children with this particular genetic variant has been associated with a decreased adherence to oral tablets and oral solutions in general. So there is actually a direct correlation. The temperature of the food, or actually the medication, is also affected. Visual impairment, because children also receive information with their eyes, and this is one reason why many of our medications are brightly colored. And then also nasal congestion, just because of the influence with our nasal passages, olfactory sensation, and also our taste buds. So again, with a survey that was conducted, they found that close to 85% of children did report taste or flavor as a primary reason for refusing medication. So this is actually similar to the slide that I had shown earlier, where a majority of the children actually say taste is a reason why they refuse medications. So what are some of the responses that children give when they describe about their medication taking process? Here are some of the responses directly from the children. First, they say it tastes like salt water, or they don't like the color or flavor. Other times, they say it tastes old, or that the medication's yucky. They say it tastes gross. It tastes like fish, although I don't know which medication this child is referring to. I'm kind of curious. It tastes horrible. They're scared to swallow. It tastes too sour, and old people like them. So for the older audience, please don't be offended. It tastes like alcohol was an interesting one. So I'm thinking, where was this study actually done? They say it tastes icky. It has an icky aftertaste. They don't like cherry flavor, and they want only blueberry or bubblegum. I have yet to come across a medication that was blueberry flavor. I know maybe Freddie has, but they can be quite demanding. But the reason why I wanted to share with this is because I think oftentimes we don't take into account what the patient or the child is actually experiencing. And knowing what they think of the medication and how they perceive it, I think is one step to understanding how we can improve the medication taking process. So, no surprise, children prefer sweet flavors. And of those children who have taken medications, the preferred flavors are cherry, bubblegum, and grape. 85% of them would have liked a chocolate-flavored medication. And again, I have not come across a medication that was actually chocolate-flavored. I'm sure there's many reasons why, but so far, not a popular flavoring for medications. Less than 5% of them do not like peppermint. So like solutions that are mint flavor are going to be a bigger challenge. And interestingly, tasteless medications are actually a little bit more accepted because they're a lot easier to mask. So tasteless or sweet tasting medications can actually minimize resistance. So what are our Hong Kong children taking? Here is a list of the most common liquid medications that have been dispensed, again from courtesy of the Hong Kong Children's Hospital Pharmacy Department. But I wanted to share this list just so you guys, just so the audience can have an understanding of what are the most common liquid medications and what flavor are they at. I think most prescribers may not know what the flavor is. I'm sure some of you who have maybe dispensed this to your children may know, but I think in general, what we can see is that a lot of the medications we dispense are actually, they don't have a specified flavor. So while this is good in that you can mask it a little bit better, this may also not be so good, because then the child, if they ask you what flavor is this and you say, I don't know, then maybe that may not be a good answer. There are a few medications that have quite I would say I would like their flavor, like raspberry flavor. Celeste is actually mixed fruit flavor, and liquid levetiracetam is grape flavor. Sometimes they may not actually be specified or advertised as raspberry flavor, but they are listed in the excipient. So we can assume or guesstimate or expect at least that this is the flavor that the child will taste. And again, just to kind of share with you guys a local perspective and what are the taste and flavor of these medications that we're giving to the patient. I didn't include color because color does vary, and I think most of them are some sort of like white yellowish type of color, except for the raspberry flavor, which I'm hoping is at least pink or red. But color is something I didn't include here, but is actually also very important in the adherence of the child. And so if the liquid medication doesn't look very attractive, that will be another deterrent for the child to take the drug. So what can we do about it? Okay, so again, it's very difficult to say what will work, but hopefully what we can do is remove some of these barriers. I've listed here some of the more common solutions that you can try. I will say that, again, each child will have their own preference. You can try to use, to refrigerate or to chill the medication. Oftentimes, this does help. You can consider ice cubes prior to administration. You can mix it with whatever food or ingredient the child prefers. For the younger children, we did see that an oral syringe tends to be a little bit easier because you can direct the syringe into the back of the mouth and the child can just swallow it, and thereby bypassing the tongue. And also with the syringe, you don't necessarily have to see the smell, or you don't have to smell it, and so sometimes this does help. Encouraging non-food rewards or small treats, and also encouraging them to move to tablets when they're older, are also other reasons. Again, I'm sure there are many other creative ways that parents use to improve medications, but these are just the more common ways. And again, no one size fits all. In terms of formulations, something to remember is that you always want to make sure you check the medication before you adopt any of these. Some medications should not be refrigerated. Some medications should not be mixed with milk. Some medications may not be compatible with certain food products. So I encourage you to always find one of us, ask your pharmacist colleagues to see whether they can be mixed. What does not work, actually, is the threats and the scare tactics. And that has been, I think a lot of parents probably will know that threatening the child, scaring them, or you can't have TV if you don't have it, doesn't work, and actually becomes a vicious cycle. And I didn't include this here because the data on that is more anecdotal. Nobody decided to research on whether scaring the child will make them non-adherent, but it's anecdotal, and again, just passing on the information for your consideration. Okay, so I've talked about, again, very briefly about pill or medication burden, drug formulation, and palatability. And while I touched upon each of them, again, not able to go through a lot of them in depth. These are just tip of the iceberg. But I hope that these factors encourage you to think about what can we do to maybe not necessarily solve the problem, but at least remove the barriers. So going back to the factors, there's many factors associated with it, but what else can we do? Well, here I have some good news and some not so good news. We do know that simplifying the treatment regimen can decrease the non-adherence. So for patients who are taking once daily doses versus 4 times a day doses, the adherence drops when you have a child who is taking a drug 4 times a day. So less frequent dosing also allows for more convenience and also less time clash. So this would actually remove the barrier with regards to school, the child is sleeping, or the parents being too busy. So this is perhaps something that you guys can consider when you're selecting your treatment regimen. And oftentimes when you're selecting a drug that are efficacious, perhaps the deciding factor would be the simplicity of the treatment regimen. The next thing you may want to consider is a dose quantity. So throughout the studies, they did say that a volume less than 5 ml is preferred. Anything more than that, we run into problems, not just with there's more medication to taste, but in younger children, it does encourage them to vomit up the volume just because of the quantity of the volume. So for our prescriber colleagues out there, you may want to consider this. And then lastly, just to encourage communication. Now, this is going to be, I think, the most challenging, and this is something that we can all do, but encouraging communication between that triad that we see with the parents, the child, and also the prescriber. And actually, parents and children were more likely to adhere when they see improvements. So one of the things I always do as part of my counseling is to give them realistic expectations. So when I tell them this drug is going to improve pain, I tell them approximately how long will it take. If it's supposed dose to improve their mobility, approximately how long. And I think giving them realistic expectations will help them not only understand the medication, but know that they should continue using the medication until the designated time when they will notice the improvement. So don't give up too easily. Okay, so here's the not so good news I was talking about. It's not that bad, but when I looked at all of these clinical recommendations that we have and things that we try to do, what does the evidence actually suggest? And we see that, for strategies that decrease the complexity of the regimen from once to twice daily, the evidence rating is at a B. Versus giving parental education, the evidence to improve adherence is at a C. And while using sweeteners, chocolate flavoring, chocolate chasers to mask bitter taste does help, the evidence rating is at a B. And so B stands for inconsistent or limited quality or patient-oriented evidence. Why is that? There's various reasons. I think this just, to me, when I came across this article, it just showed that each child is different. And what may work for one child may not work for the other. And so really, what I aim for this talk is not to necessarily give you solutions, but to make you guys aware of what are some of the challenges and how can we remove the barriers. So I have just a few more minutes where I'd like to share with you some of the newer concepts when it comes to medication adherence. So when we look at the literature, how adherent are children? Actually, there's no consensus for what is considered adherent or not adherent. Some studies use an arbitrary cutoff. Some use situational outcomes. And in addition to that, there are various definitions. So when you take a dose more than 80%, you're considered adherent. Or if you don't miss a dose in the last 3 days, you're considered adherent. Now, I'm raising this up so if you decide to inquire about adherence in your practice, you may decide to use some of these definitions as a benchmark. However, I said that there were some new concepts that are coming out, and what we're moving towards now is actually not just adherence rate or adherence threshold, but also this concept about drug forgiveness. And drug forgiveness, again, personalizes the medication regimen by referring to the number of consecutive doses that can be missed while still maintaining a therapeutic effect. And so this is a newer or perhaps a more contemporary way that we're trying to measure adherence. If a child misses a dose of perhaps lisinopril for 1 day, they may not have the same detrimental effects as if they miss a dose of insulin. And so if you look at the duration of action of the drug and also the dosing interval, a lot of the studies nowadays are moving towards was the child within the drug forgiveness window? Because expecting a 100% compliance may actually be unrealistic, and even 80% may also be too high for some cases. And it really is dependent on the drug and also the child's disease state or the condition. So bottom line is that no adherence threshold is universally acceptable to all drugs, hence making the situation, again, more complicated in that we have to look at each drug, each patient, each condition separately. There's a lot of tools to measure. Some of them are more academic and some of them are a little bit more basic. I'm including these here just for you to note in case you want to use some of these or adopt some of these to measure adherence in your practice. So in summary, it is complicated. So medication adherence and non-adherence is a vast and multifactorial complex problem. It is a universal problem, though, with no one-size-fits-all solution, and it does require a multidisciplinary approach. So while I presented factors associated more closely with pharmacy, I think I can say we are all in this together. We need collaborations from our nurses, our physicians, our child psychologists, social workers, parents, classmates, friends, Facebook friends, Instagram friends, whoever, to solve this problem. So while the exact solution remains elusive, I think that my takeaway message for you guys is recognizing the factors that can contribute to non-adherence, and removing those barriers is a possible solution. And understanding that the extent of the problem and personalizing our approach for each child, each drug, each condition is the first step in the right direction. So with that, I thank you everyone for your attention.
Yeah. Okay, thank you very much, Celeste, for your wonderful talk. Maybe I just start asking the question from the floor. Is one of the questions is the flavor of the drug intrinsic? Can we change it, or just adding syrup to make it sweeter? What do you think?
Okay, this is a good question. So thank you for asking this. So most of the drugs will contain an excipient, and that excipient is what dictates the flavor. Can we change it? Yes and no. There are actually some products that can alter the flavor of the drug. So for those of you who may have visited North America, we actually have this product called Flavor RX, which is a compilation of different flavors that you can add to a commercially available product that already has its own flavor to change the result. So for example, let's say I'm dispensing amoxicillin, and the amoxicillin comes in strawberry flavor, and the child actually prefers, I don't know, orange or banana. You actually have options to change that flavor a little bit to match more closely. I have not tried this myself, so I cannot attest to how effective the the flavor change is, but it is quite accepted. So the short answer to it is that yes, there are ways to change it. I think rather than changing the flavor, what we try to do is to mask the flavor. And so we can mask it using syrup is one way to make it sweeter. Some mask it using chocolate milk. Some have actually used peanut butter, which is kind of interesting, but taste masking is one thing. And so one of the things that we hope to do is to find more ways where we can mask the taste rather than changing it altogether. So I hope that answered your question, even though it was not a very clear answer, but hopefully it gave you some ideas.
Yeah. Okay. Maybe I can share the experience
Yeah,
because
please do.
in the past we use the syrup as a suspending agent to do the compounding.
Yeah.
But we come across a lot of parents complaining that the tooth decay.
Right.
Yeah, because most of the time they give the medication at the night time.
Right.
And without after
Brushing
brushing
your
the teeth. Yeah, that's exactly. So we are now moving on to using some of the non-absorbable suspending agent instead of the syrup. So that means that now the what's so-called the extemporaneous compounding preparation, we don't have the taste to add because we don't have the sweet taste. We just have a translucent solution for every extemporaneous compounding formulation, and we only concern about the quality of the medicine, but we sort of neglect the color or the taste of the medicine. So so we have some problem with the compliance, and especially in children's hospital, because we have all of the cases here is mainly of the transplant and the oncology problem. If the compliance, we will have a big problem for the children. Yeah, which is maybe a disaster for the. So that I think the parent know that the medicine have to be taken, but the problem is sometimes it's the side effects of the medication that really causing the child to vomit or this kind of thing. So I think So we try to do what you have mentioned in the last slide, is to have the personalized plan for them, because but this is a very tedious task. We have to have build up a relationship with the child and the parent at the ward level before discharge, because at the outpatient setting we can't do much. We have to discuss with them and build a long-term relationship so that they trust that the medication could help them, and then we trial and error. We encourage feedback from the parent or even from the child to say how do you feel? Is there anything we could adjust the frequency, or even to suggest to change the alternative medication to have a better taste? So I think this is the main role of the Hong Kong Children's Hospital Pharmacy, to see how we could enhance this kind of the experience, the patient experience. Yeah. Okay. Yeah.
Yeah, I'd like to follow on that remark that you just made, Freddie. That I think we should hear the voices of the children as far as medications are concerned. Because I just talked to my director over lunch. And she still remember many years ago that there is a particular kind of flavor, particular kind of formulation that make her very sick. And then she remember till now.
Right.
So I think we have to hear the voices of the children.
Exactly.
What are the good things? I mean, just now you mentioned about the raspberry, the grape, etc. I personally did not like the grape. Okay? But I think genetics make some point there.
Right.
And perhaps you have pharmacy students.
Yes.
I think they should come to as a project, one of the projects, talk to the children. So what are the flavor that you like? What are the flavor that you do not like?
Yeah.
And
Actually, that was actually a project that we hoped to carry out last year, but then COVID happened.
Yeah, unfortunately.
Unfortunately. But actually, I think there would be some differences with the local population, what kind of flavors that they like. And I think we need to ask the children who have taken medications.
Yeah.
Because they cannot expect a grape flavored medication to taste like grape juice. I think that's an unrealistic expectation. It will always taste like medications, but how can we at least minimize that nasty taste that they describe? But I very much agree with you. I think that would be a really good project.
I think for those who like wine, I think perhaps we treat it like something like wine. You look at the color, you smell
To
it,
smell it, yeah.
you taste it. How is the palate like? And then aftertaste, I think we should have some sort of tasting
Right.
before we really give them to the children.
Right. I think
The other experience that we have is that sometimes, the children, they take it very fast, okay? Well, in the hope that at the end, they will have some reward, just
Right.
like you mentioned. Perhaps I would have some Smarties, M&M. Does that work, actually?
depends on the child. So actually, the more mature the more mature children may for more mature children, that approach might work. Like I'll give you. It can be, I don't know. Some people are motivated by money. Some people are motivated by toys. It really depends on what motivates the child. And so I think there are some cases where the child knows that taking the medication will make them feel better, and they get a treat at the side. So yes, I think so.
The other thing I'm thinking of, because I'm involved in child life or hospital play, that perhaps we can use some distraction play for small kids. That if you distract them, perhaps they would, take the medicine more easily. I think that may be another good project.
There's actually puppets that will that the parents can use to deliver the medication or hide the syringe with the medication. I haven't seen it locally, so I don't know if they use it here, but there are such puppets.
Okay, there's another question from the floor is how to use the syrup in medicine for insulin-dependent DM children.
Okay, so the question is,
Do we need you to use the syrup or,
okay, so again, good question. So how do you use syrup in children with insulin-dependent diabetes? And so this is actually another challenge that we have with masking the taste or making the question a lot more easier, a lot more acceptable for the child, is if they have a contraindication. And so for some of the syrups, there's actually sugar-free syrups that are made specifically for patients with diabetes. So this is, they're still sweet. The sweeteners are still sweet. They're not necessarily called sweet syrups. They're referred to as sweeteners. But they have excipients that are artificially flavored that will not increase the glucose. So things like aspartame are a very common excipient that is used to sweeten it. So there are solutions for this as well.
Another question is there any tricks to help the child with epilepsy to swallow the slow release tablet? Is the formulation part.
Any trick to help a child with epilepsy swallow a slowed release tablet?
We usually don't use the slow release for a child, right? If you could find the plain solution or the tablet.
So I think trick. I would say usually for children with epilepsy, we would use a liquid formulation.
Yeah.
However, if perhaps the child is older and they're still not able to, or the preferred formulation is a slow release tablet. This is a bit difficult because you cannot crush or break a slow release tablet.
Sometimes, for example, we have a different strength. So, for example, the children have to take 200 milligram tablet twice a day, but it's a little bit bigger in size. So we would switch to two tablet with 100 milligram.
So
the
smaller,
sustained release also,
smaller
so we can
tablets.
trial and error and see if the children can tolerate it or can take it. How about the other question is so we have so many questions here. Can we mix the drug with ice cream?
You know, this is not the first question. Is this apparent? Because this is not the first. Okay. This is not the first time I've been asked whether you can mix it with ice cream. So most children do like ice cream. And so my answer to this is it depends on the drug. Because if the drug is okay with dairy products and is okay in a cold environment, then I would say yes. But I would encourage you to maybe mix it with just a small portion of ice cream rather than the entire tub or gallon. I don't know, we're talking about encouraging, so I don't know how much encouraging you were hoping to do, but maybe a small amount of ice cream, personalized size, so that they can still enjoy the ice cream, but make sure that they complete the whole dose. So the answer to that is if the medication is compatible, then that shouldn't be a problem. And that's actually a good approach because then they can just take it right away and it doesn't have to be kept for a long time.
Yeah. Another question is this common to use to mix with the fruit juice? Is this a common practice in hospital? I don't think so.
So mixing it with fruit juice. The most common use is to mix it with fruit juice. This is a common practice in hospital. I don't think it's a common practice in the hospital. I think most of the times they mix it with water or you kind of dissolve, and then or they use applesauce, something a little bit thicker. The fruit juice depends on the fruit juice. Like they do have a lot of acidity to them and a lot of sugar, and so. And in terms of taste masking, so going back to palatability, also the texture of the medication is a factor. So the fruit juice is a little bit too thin to actually mask the consistency. So not a common approach, but you know, if it works for the child, then I have nothing against it. I have nothing against it.
Okay, maybe this last question is it's not a question, it's a comment, right? It's just the suppository for cough and runny nose in France. I don't have no idea of how it's not available in Hong Kong, right? You mean the suppository for the cough and runny nose? They may have in France, right?
Yeah. I haven't come across a suppository for cough or runny nose. We do have suppositories for like Panadol suppositories for fever.
For nausea and vomiting. Yeah.
Nausea and vomiting, yes. But I don't recall. I'm not aware of a suppository for cough. But again, it could be just we have different drug products available in Hong Kong, and that product doesn't seem to be available. But I'm curious about it, so I will look it up. Thank you for asking this question. I will look it up and see what the product is called. But yeah, great. Thank you.
Yeah. Okay. Yeah. Thank you. Thank you very much,
thank
Celeste.
you.
Okay. On behalf of Charles Sim, Sophia.
Oh.
So you're assuming to have the phone, right?
Okay.
Yeah.
Thank you so much. Wow. Thank you.
Thank you very much for your excellent talk.
Thank you.
好，多謝 Celeste 同埋多謝Freddie。其實好精彩啊！就我諗冇乜人即係仔細咁諗下啲小朋友點樣食藥啊！咁其實原來頭先睇 study 真係都幾驚嘅，其實食到幾多咧咁？咁我諗呢個係一個好嘅 reflection。咁佢而家有個名喎呢個阿Yvonne 嚇。
Oh, thank you. I don't know how to pronounce
Coqueluche.
I don't speak French, but I thank you for letting us know the name. I will still look it up. Like I think I'd be interested to see what is in this product and how does it actually benefit with the suppository formulation.
我諗呢個
Thank you,
個個父母都好想要呢個嚇，即係 suppository 好過 oral。
Yeah.
咁就今日好精彩啦。咁咧就我頭先諗到一樣嘢咧。頭先阿 Freddie 開始之前同我講啊，其實香港啲 pharmacist 即係都諗緊 form 一個 college 啊。咁我覺得呢個真係非常之好嘅嚇。我哋醫生有啦，護士有啦，midwife 有啦。我都好希望藥劑師咧可以快啲 form 到 college。咁就即係有一啲 professional 嘅 advancement 啦。training 啊 accreditation 啊 education 啊 assessment 啊咁樣。咁我喺度咧呼籲下我哋醫生，尤其是兒科醫生同埋護士咧，都盡量俾多啲 support 佢哋嚇。開頭真係幾難做嘅嚇。咁但係我哋俾多啲 support 佢哋，多啲 interaction 啊 clinical pharmacy 我諗好重要。咁頭先嗰啲話題其實我哋都好少諗嘅。但係又好重要嘅，我哋唔諗其他細路仔都食唔到藥嘅，即係咁，所以我哋希望喺度呼籲下大家，如果有機會呢，佢哋揾我哋幫手呢，我哋一定要幫佢哋嚇，希望佢哋快啲可以成立咗呢個 college，咁就幫到啲小朋友，又幫到屋企人。咁我頭先講啦，我都希望Child Life 嗰邊呢都會諗下點樣可以幫到啲細路仔呢食藥食得好啲，尤其是 distraction 啊，或者頭先話 counselling 啊，預早話俾佢哋聽 ，prepare 得佢好啲，佢可能又中意食藥啊咁樣。咁 anyway 今日就好多謝 Freddie 啦，好多謝 Celeste 啦。咁啊 Celeste 話其實佢有好多 topic 佢都可以講嘅。咁咧我希望即係嚟緊幾個月之後啦嚇，或者半年之後咧又幫我講第二個 talk。咁就pediatric 嘅 pharmacy 其實係好重要嘅嚇，因為真係太少人做呢樣嘢嚇，我哋個 population 太細，但係重要嘅呢個。咁啊再次多謝兩位。咁嚟緊嗰3個禮拜呢，就我哋係講 research 啦，由我哋 research office 兒童醫院 research office 同埋啲大學呢，我哋一齊搞咗3個 talk，就係星期5嘅。咁就最後尾嗰堂係有啲 panel discussion。咁有興趣做 research 啊 interpret 啲 research 嘅同事呢，就密切留意。今日我會再出一個 email。上個禮拜我出嗰個寫 coming Friday 就唔係今個禮拜5，係應該係下禮拜5，我嗰度寫錯咗。咁啊，下禮拜5開始3個星期5咧都有research 嘅 topic 喺 Child Talk。咁就今日開始登記接受呢個疫苗啦嚇，我都希望多啲人打啦，香港快啲行出呢個pandemic 嘅 situation， 早啲回復正常嘅生活。好，咁但係 before that 希望大家都小心啦，照顧你自己同埋照顧你周圍嘅人。好多謝大家，下星期5再見，拜拜。